I think that we'll move on, since there's no other questions, to Dr. Parkman. Dr. Parkman, who is kind enough to provide some additional information just now, is a professor of medicine at the Lewis Katz School of Medicine at Temple University. He is really the master of motility. He is known throughout the country as the leading expert on motility. And when you think of motility, he is the man to think of. The only unfortunate part of that is sometimes patients have to wait a little longer to get in to see him. But he is an excellent clinician, a wonderful person, and a world authority on motility. So in moving along with our lecture, we are privileged to have Dr. Parkman's input today and learn about different motility disorders of the gastrointestinal tract.
Well, thank you, Dr. Lefton, and thanks, Dr. Ortiz, also for mentioning me earlier. It's nice to have a fellow Temple person on the program. I was asked to talk about motility disorders of the GI tract, and thinking about which ones to talk about, I thought for the audience it'd be good to talk about the very common ones that we see day in and day out. And these are the small and large intestine motility disorders, which include the common diagnosis of irritable bowel syndrome and chronic constipation. Now, irritable bowel syndrome, this is common. It affects about 5 to 10% of the individuals. We often think it is a chronic condition, but there can be a relapsing and remitting course. I usually think that maybe central influences like anxiety, depression can aggravate the patient's symptoms. An interesting risk factor, which has been shown in outbreaks of food poisoning and things like that, is an acute enteric infection. After that resolves, the patients that have these have a high incidence of developing irritable bowel syndrome. So it's actually interesting to us in the motility world, what's going to happen after our COVID pandemic decreases? Are we going to see a lot more of these patients with functional GI disorders, especially irritable bowel syndrome? Now, IBS is a multifactorial condition with both transit problems. That's what we've harped on in the past, but now there's also what's called visceral hypersensitivity, where people are have exaggerated responses to sometimes even common motility patterns that occur every day, like the phase 3 migrating motor complex. It's thought pathophysiology, that there's a disordered communication between the gut and the brain, so that things in the GI tract are then amplified in the brain to give symptoms. Now the investigations are the relationship of dietary factors and what's been studied in the last 5 to 10 years, the gut microbiota. And there's even been studies with fecal transplantation in IBS. My observation of that literature is it still needs some work to be done. Now, the important thing, I'll harp on this several times, IBS is very common. It's you want to do a limited number of investigations and actually come up with a diagnosis early on for the patient. Otherwise, the patients keep on coming around to different centers. I see a number of patients that have been seen by 3 or 4 GI people in the Philadelphia area. Then they come to me, and each person does their own little evaluation. Now, the mainstays of treatment, it's usually a primary care thing, but things like be very empathetic to the patient about their symptoms, how it interferes with the life, patient education, dietary changes, simple things initially like fiber, especially soluble fiber, antispasmodic drugs. And then the new agents that are coming out are usually for the severe symptoms and we'll talk about these new agents later on. Now, in our GI community, we have what's called the Rome criteria. And these investigators have gone to Rome 4 times for discussions. And so they get together, the United States with the Europeans, with the Asians, get together and come up with unified ways to to define these disorders. So IBS is now defined recurrent abdominal pain that's associated with change of bowel habits. Usually it's related to defecation, the abdominal pain. There can be a change in stool frequency, and we'll talk about that, or stool form. For instance, here we show, and I think a lot of GI people have on their chart in their rooms, is what's called the Bristol Stool Index, that characterize, the patients can look at and say, oh, this is the shape of my stool. Normal is about 3 to 5, but the hard pellety stools, like type 1, are often associated with the delayed colonic transit, and the watery stools are often associated with rapid transit. So we divide IBS into diarrhea predominant, constipation predominant, and alternating diarrhea and constipation, depending on the percentage of how much they have loose watery stools versus hard lumpy stools. So if it's predominantly loose watery, it's diarrhea. Predominantly hard lumpy stools, it's constipation. Or if they have both of them to a significant degree, it's IBS mixed. And actually, patients love looking at this chart that we have in our rooms and telling us exactly what sort of stool form they have. But this helps us in categorizing the patient into different components, because the treatment obviously depends if they have diarrhea predominant versus constipation predominant. Now, I mentioned that the cause of IBS is multifactorial. The key things are altered motility that I've discussed before, but there's been a switch to altered sensation or hypersensitivity, and each of these are impacted by psychosocial factors. I usually describe to my patients that the vagus nerve is bidirectional. So things that they're feeling, or anxiety, depression, that is then goes can be sensed to some degree in the GI tract that can give rise to some symptoms, and then the symptoms actually go back up where there's hypersensitivity. So it's a double whammy that some of these patients have, where this altered sensation and psychosocial factors can interplay with one another. I'm sure we've seen that in our patients, where when the patients are markedly anxious, they give rise to worsening irritable bowel syndrome symptoms. Now, in the last 5 years, or even longer, inflammation, a chronic inflammation, the GI tract can lead to immune dysregulation, and that can give rise to irritable bowel syndrome. I mentioned before that acute enteric infections often precede irritable bowel syndrome. There's some mechanisms that have been associated with this. One of the things is that when you do, in research studies, when you do biopsies on flexible sigmoidoscopy in patients with IBS, you can see an increased number of mast cells, sometimes eosinophils, that they're indicating there might be low-grade inflammation, and these mast cells or other inflammatory cells might lead to release of cytokines, and then that gives rise to another pathway that leads to irritable bowel syndrome and symptoms. This is an older study, 2 decades ago, that looked at patients that were hospitalized for gastroparesis. And the patient's age shows they did not have irritable bowel syndrome to begin with. They came in with an acute gastroenteritis. And then when they followed them up 3 months after their acute onset of gastroenteritis, when the gastroenteritis had been in remission, a quarter of them had symptoms of irritable bowel syndrome. And they things that were associated with developing IBS was persistent mucosal inflammation, as well as higher psychosomatic stress scores. We have questionnaires that can measure hypochondriasis. anxiety, somatization, and these things also give rise, besides the underlying acute infection, to irritable bowel syndrome in some patients. Now, in the prior slide, in making irritable bowel syndrome diagnosis, get the defining symptoms, the abdominal pain, altered bowel habit, things that are supportive of the diagnosis is shown here. The pain's relieved or worsened with bowel movements. You often have other symptoms like bloating, flatulence, and they can have other non-GI symptoms. Irritable bowel syndrome is associated with migraine headaches, interstitial cystitis, and other disorders. Also, there can be overlap with other functional disorders, especially functional dyspepsia. So generally, we like to be up here trying to make a positive diagnosis. Usually, I like to try to mention irritable bowel syndrome on the first visit, that let them know that that's what I'm thinking of. Now, there are some alarm features that we all know about that are shown here. If they're above 50, obviously, if they're losing weight, if they have unexplained anemia, and other things, it might lead to more evaluation. Generally, for irritable bowel syndrome, we follow the guidelines for colonoscopy. That is, do it in the patients if they're 50 or above. Now, there's a push to doing the colonoscopy if they're age 45 or above, or if they have some of these alarm features, we'd be more prone to do a colonoscopy in these patients. So it's a simplified algorithm in clinical practice: abdominal pain, altered bowel habit, assess the patient, and actually try to come up with a positive diagnosis, or at least tell the patients this is what you're thinking of, because you don't want to leave the patient hanging that there could always be something else going on, because there's always tests that we can do on patients, and then they get cycled among different physicians. Now, for irritable bowel symptoms in particular, for the patient, some of the things that I like to cover in the history is, what are the, can you identify triggers of their symptoms? And usually in my field, it's mostly stress in my practice, but actually something I've been doing lately is getting a good soda or soda intake. Are they taking diet soda and things like that? How do the symptoms impact on their daily life? And you'd be surprised how much it does. Actually, irritable bowel syndrome or functional disorders can give rise to more days out of work because they're so much more common. Assess for psychological comorbidities like anxiety, somatization. Look for other diagnosis. I mentioned some urologic things like interstitial cystitis, but also fibromyalgia, migraine headaches. And then also start thinking about in the patient, what are their preferences for treatment? Some of the patients I see don't want to be put on any medicines. And I'm empathetic with that. And then we try maybe some counseling and other things, and maybe some herbal remedies or treatments that they're prone to. Now, here's some of the agents that we give for patients with irritable bowel syndrome. Remember, the diagnosis is mostly made if they have abdominal pain. Okay, so the treatment for this is the symptomatic treatment are things like antispasmodics. It's crossed out here. We don't give opioid analgesics, and I try not to even embark even what I used to call a kind of a partial opioid analgesics like tramadol, because in my practice, you put the patient on tramadol and they want something a little stronger, then all of a sudden you're talking about Percocet and other things. So I just stay away from this altogether. And actually, the only patients I have that I'm giving opiates to are the ones that I gave them to them a long time ago when that was the practice, and I see them every month for their monthly refill. So for the diarrhea, we give things like Lomotil, and Imodium. And there's also other agents like Vyburzi, which has been approved for irritable bowel syndrome, diarrhea predominant. Remember, that can only be given if the patient has a gallbladder. If they've had a cholecystectomy, Vyburzi increases the risk that they might develop pancreatitis, as well as drinking alcohol does. Now, for chronic unexplained diarrhea, sometimes associated with IBS diarrhea, some of the other things we go to is, for instance, cholestyramine for bile acid diarrhea that I'll talk a little bit later, and even the 5-HT3 receptor antagonist olocitron, which was brought out on the market, taken off the market, and now it's back on with actually less supervision. That in very severe cases, I give this, and it's helpful for the diarrhea and the abdominal pain. For that agent, you want to be careful that you don't develop constipation, because some of those patients in the trials had ischemic colitis also. Constipation, I'm a big proponent on fiber, laxatives, polyethylene glycol, but then I go to some of the secretagogues, things like Amitiza and Linzess and Trulance. And then now there's a couple pro-motility agents that have come back to us. The 5-HT4 agonists are now approved for constipation, like Prucalopride. And now last year they brought Tegaserod or Zelnorm back. So these are at our armamentarium now. Personally, I think that the patient has to be pretty severe off to get put on these lower agents like Tegaserod or olocitron, because of the you got to be cognizant of the side effects of these agents. So you have a patient with irritable bowel syndrome, constipation, at least that's what you think. What's going back in the back of your mind, okay? Are there other causes of the patient's symptoms of constipation? Could this be just chronic idiopathic constipation, of which a high proportion is slow transit constipation, and some of the patients have dysenergic defecation? So instead of irritable bowel syndrome, is it a primary constipation predominant? So usually they get in the IBS-C if they have associated abdominal pain. The research now is showing that the IBS-C is on a continuum with idiopathic constipation, and just depends a difference of how much pain the patients have. And then don't forget about medication-induced constipation. Now, unfortunately, a lot of our patients are on narcotics. I'm to blame for some of them, but there's actually specific medications that can be used for narcotic-induced constipation. And other agents too. I mentioned the antispasmodics can be helpful for the abdominal pain, but these antispasmodics are often anticholinergic agents. And if you're giving them too much, that can actually cause constipation. Actually, when we get gastric emptying tests in our patients with possible gastroparesis symptoms, we want to make sure they're off narcotics and off anticholinergics, because these can at least delay stomach emptying, and narcotics can also delay colonic transit. So our treatments for irritable bowel syndrome, constipation, they're shown here, and I believe you're going to be getting a copy of these slides, but I like to first start out with the constipation, starting out with fiber supplementation, and generally it's soluble fiber. I'm kind of simple. I only use two. I use Metamucil and FiberCon. Metamucil is the powder, FiberCon is the capsule, because some people don't like the fiber. I sometimes use, then my next gradation is to try to deal with the constipation. I use osmotic laxatives like Miralax or magnesium oxide. And I'll talk about that a little bit later. The studies show that this increases the bowel movement frequency, but might not affect the pain if they have true irritable bowel syndrome constipation. But to me, I like to try to help regularize the bowel movement, see how much of the pain is left over. There's stimulant laxatives that people can use. Personally, I don't use these that often. My next step is to go to some of these pro-secretory agents, and I have 4 of them right here. For side effect profile, and easier to get. My personal one that I use is linaclotide because I find it a little bit easier to get. And Amitiza, I'm sometimes worried about the nausea the patients might have. Trulance is good, but there seem to be too many reasons why the insurance companies want a pre-authorization. And then I go to the prokinetic agents, the 5-HT4 agonists I'll talk a little bit about. Now, there's a new pro-secretory agent available. We've used Amitiza, we used Linzess, Trulance came up about 3 years ago, and now tenapanor is coming shortly. I don't think it's actually out yet, but it did get approved last year. And this agent showed that it overall improved patients with irritable bowel syndrome, constipation, 27% versus a placebo rate of 18%. You might think, boy, that's not a very good gradation, but actually that's what all the other studies have shown. And in the pharmaceutical trials, they've tried to really decrease the placebo rate because in the past they were as high as 30 or 40%, and there was too much noise to see if an agent worked. But this agent got approved. It helps with the abdominal symptoms and the overall global symptoms, and it should be coming out shortly. I have not personally given it. So we talked about irritable bowel syndrome, constipation. Now let's go to irritable bowel syndrome, diarrhea. Personally, I see this less than our patients with irritable bowel syndrome, constipation. That might just be the type of patients I'm seeing. But some of the things in the differential you should be thinking about is, could this be bile acid diarrhea? Have they had a prior cholecystectomy? Could this be microscopic colitis? So often we might do during the colonoscopy, if that's indicated for the patient, do biopsies to look for either what's called collagenous colitis or microscopic colitis. Celiac disease can also bring on diarrhea. And so sometimes we do upper endoscopies or checking the TTG on the patients. Could this be food intolerance? Inflammatory bowel disease is sometimes hard to diagnose. The patients often get a colonoscopy, but did someone actually look at the terminal ileum? I mentioned post-infectious disorders, be cognizant of medication. And I'm always on the hunt for small intestinal bacterial overgrowth. Now, a new disorder that's come up is this, I'm only bringing this to your attention, is sucrase isomaltase deficiency. And this is where there's a deficiency of this enzyme, sucrase isomaltase. And if there's a deficiency, they have problems with maldigestion. So they have abdominal pain, bloating, gas, and diarrhea. Wow, sounds like irritable bowel syndrome, diarrhea predominant. This study that was done took patients who fit the diagnosis of irritable bowel syndrome, diarrhea, or mixed. They underwent the special studies, which were some blood tests as well as special biopsy processing, and found that of the patients with IBS, diarrhea, or mixed, actually a third of them had this disorder, sucrase isomaltase deficiency. Why it might be important is it responds differently than irritable bowel syndrome. It responds to starch and sucrose elimination. So I just bring this to your attention. Personally, I don't go into this in the patients I see, but maybe there's a lot of discussion about this in our GI field right now. Well, what else can we do? There's actually a blood test available that tests for certain antibodies called the antivinculin and anti-cytolethal distending toxin antibodies. So there's a commercial test. And the thought is food poisoning can lead to bacterial toxins and then to autoimmunity. This can lead to gut nerve damage, bacterial overgrowth, and then the patient has irritable bowel syndrome. So you're seeing the patients with irritable bowel syndrome, and some of these bacterial toxins, the patient can develop antibodies to cytolethal distending toxin, and the autoimmunity pathway can lead to antivinculin antibody. Here's a study that they looked at patients with irritable bowel syndrome, diarrhea, and compared it to patients with inflammatory bowel disease. They found that these antibodies had good specificity, but unfortunately low sensitivity. So good specificity means if you test for the antibody and they have it, it's likely they might well have post-infectious IBS, but if they don't have it, it doesn't rule it out. Along with the inflammatory picture, this meta-analysis looks at patients with inflammatory bowel disease and shows that actually once the patients get in remission, a lot of the patients have persistent symptoms. And this is often thought to be irritable bowel syndrome. It was found to be in this meta-analysis more common in Crohn's disease and more common in psychological comorbidity. I'm smiling right now because the key people that know a lot of the treatments for unexplained irritable bowel syndrome are actually our inflammatory bowel disease experts, because they're dealing with these patients a lot and they're coming back with recurrent symptoms, even though they don't have measurable underlying disease. Now at Temple, we do what's called breath testing for bacterial overgrowth. And we often do that in patients with irritable bowel syndrome, diarrhea, but also in constipation predominant. Our machine measures hydrogen, methane, and also carbon dioxide as a correction factor. There's a new machine that measures hydrogen sulfide, and that's always been thought to be the missing gas that can be detected. And so the hydrogen producing bacteria can also produce methane and hydrogen sulfide. And this studies by Mark Pimentel looked at the increased hydrogen, which is how we usually make the diagnosis of bacterial overgrowth, suggests bacterial overgrowth, but it's not associated with symptoms. But it's actually the hydrogen sulfide is related to the diarrhea and urgency in patients with diarrhea. And actually the methane is important for the constipation symptom. So anyway, this machine's come out. We don't have it. And actually for about 6 months, we weren't even doing breath tests in the middle of the pandemic. Now we're doing them, but they still have to get tested for COVID before they came in because the patients are doing a lot of breath sampling. So let's go back, irritable bowel syndrome, diarrhea. How do we deal with this? You might modulate the gut flora, and I'll talk about a study with rifaximin. You might modulate the gut flora with probiotics. For persistent symptoms, I mentioned before, cholestyramine. Usually I put these patients on some simple things initially. I give them hyoscyamine or Lefton short acting to see if that helps improve the pain. Peppermint oil, like that's available in IBGard is very helpful. And then for persistent symptoms, I go to this agent Vibersi. For very severe cases, I might try elocitron, or if they have a lot of abdominal pain and with the diarrhea, I put them on a symptom modulator, and I pick one that might also help the diarrhea, and I often go to amitriptyline or Elavil. Here, when the AGA and ACG got together several years ago, they looked at these agents that are approved: elocitron, Vibersi, and Xifaxan. Showed presented how much data was there. Showed that each of these were generally of moderate evidence that can help the patients. With some caveats, elocitron is generally given for women only. I mentioned that its side effect is constipation. Vibersi, you need to avoid if the gallbladder is removed. Actually, now it's contraindicated if they've had a cholecystectomy or they have alcohol abuse, because it can lead to pancreatitis or more severe liver problems. And Xifaxan has been suggest to be helpful for irritable bowel syndrome, diarrhea predominant. What we do at Temple is actually, we've been doing this for a long time, is at least what I do, is I get the lactulose breath test to see if the IBS diarrhea patients have evidence of bacterial overgrowth. And then if they do, I put them on Xifaxan. This study here showed that the response rate to Xifaxan was markedly improved if they had a positive breath test compared to they have a negative breath test. So they had positive results of about 60% compared to if they had a negative result about, let's say, 35%. So I've generally reserved Xifaxan for my IBS diarrhea patients if they have a positive breath test. Although for billing purposes, you have to say they have IBS diarrhea. Something that's come up in the last 3 years, kind of resurrected, because unfortunately we don't have a test to diagnose bile acid diarrhea, but it's underappreciated. This symposium that was held a couple years ago at DDW, 28% of patients with chronic unexplained diarrhea had bile acid diarrhea, and in the United Kingdom, they're diagnosed a little bit easier because they have this special thing called the selenium or the CCAT test that is a radioactive test that see if they have bile acid diarrhea because the radioactivity gets secreted into the intestine. A lot of the patients that they described for bile acid diarrhea had urgency, foul-smelling, watery diarrhea with bloating, and patients were treated with cholestyramine generally, and there's some other binders that sometimes you can use. This symposium actually nicely looked at, well, what if the patient doesn't respond to cholestyramine and you really think they have this? Well, you can ensure optimal dosing. You might add an anti-motility agent or try another sequestrant rather than cholestyramine. Try one of these other two. In the Mayo Clinic, they have this test, the 48-hour fecal bile acids, while on a 100-gram test as a way that they can measure test patients for bile acid diarrhea, as well as they have a blood test called the C4 test that is associated with bile acid diarrhea. In their studies, again, similar to the European group or the prior slide, 26% of the patients, the risk factors prior cholecystectomy and the presence of nocturnal diarrhea, and they found that cholestyramine was effective in about 75%. So this is some of the things in GI we have in our armamentarium. If patients have persistent diarrhea that's not responding to a lot of usual medicines, we often try cholestyramine. I warn the patient that it's generally not very palatable, and so to mix it with things like apple juice or something like that. Also, I tell them not to take it with other medicines because it can bind other medicines. Now, if you're taking care of a lot of irritable bowel or functional GI disorders, you often end up using neuromodulators. And this slide here kind of goes over some of the neuromodulators we use. For instance, the mainstay is usually the tricyclic antidepressants because these often decrease pain. If the patient doesn't have diarrhea, we try the ones that have less anticholinergic activities like dizipramine or nortriptyline, whereas, as I mentioned before, if they have diarrhea, might want to try amitriptyline. And actually, for IBS constipation, sometimes we use this SSRI shown here, and because there's some data that the SSRIs can improve small bowel transit, maybe will help their constipation. Here are some of the other agents I use for other conditions. Here's speaking of IBS, here's the meta-analysis looking at antidepressants in irritable bowel syndrome. Looking at the tricyclic antidepressants, which I generally use. Again, I forgot to mention, we start at low dose amitriptyline. I start at 10 milligrams and work up to 30. I then usually re-see them at that time and decide whether we should continue that sort of treatment. The tricyclic antidepressants had an improvement versus placebo, 57 versus 36. So delta of 20%, actually higher than the other agent I mentioned before. The number needed to treat was 4.5. So you generally have to prescribe it 4.5 times to get one patient that responds, which actually, quite frankly, is pretty good compared to our other agents that we try. And then there is a slightly increased risk of side effects like drowsiness and dry mouth. Here's the response rate to the SSRIs. The number to treat was higher than the patients treated with TCAs or tricyclic antidepressants. The FODMAPs are, people know this, and actually the patients usually say it wrong. If we want to try this armamentarium, because these FODMAPs can cause bloating and sometimes diarrhea. But what we do is we put them on a low FODMAP diet. The patients generally say they're on a FODMAP diet. We want to stay away from FODMAP diets if the patients have a lot of bloating and diarrhea. Here's the diagram that I give my patients. I got this on the website. I'm sorry, it's a little bit blurry. And I tell the patient, I give this to them, and I say, you have to eliminate these foods for the first 4 weeks, and we'll see what happened to your symptoms. And I show them these are things that you're able to eat up here. Then after 4 weeks, what you do is you add one of these columns a week and see if those particular foods precipitate your symptoms. And if they do, you know you have to stay away from that column. And then you try another column, like here's the milk column, and see if that aggravates the symptoms. And then you go through each of them. And often the patients cannot come up with 1 or 2 columns that are precipitating their symptoms, and they stay away from that. It's thought in our literature that staying on a low FODMAP diet persistently is not a good idea, because this can lead to malnutrition as well as low vitamin levels in some important vitamin areas. And so again, just to say here, the low FODMAP treatment, you take the low FODMAP diet for a month, reintroduce the foods over 2 months, and then adapt the diet for that particular patient. Here are some of the trigger foods, some of those columns. Most of them in this lecture that Dr. Che gave a couple years ago, most of them were the lactose foods that were precipitating their things. Now, I mentioned that continuing the low FODMAP diet can be deleterious. It can cause constipation. It can cause calcium deficiency. You could also give them an eating disorder, this new one called avoidant restrictive feeding disorder, where patients are very picky about what they eat. They get overly picky and they can't eat anything. And that's what some of these patients might happen if they stay on the low FODMAP diet. Also, it's somewhat expensive. Now, I used to give probiotics a lot. And I would give patients probiotics. I had my hierarchy of Align, Visbiome, Fluorstar that I would give. A number of patients say they were doing well. When the AGA looked at this a couple years ago, they found that they could not make any recommendations in IBS because there was just not enough known. The overall quality evidence was low. So they just said, we can't even bring up this, and we just need more data, because their studies had been done, but they weren't very, either not supportive or poor quality. In addition, there is a study that came out by Dr. Satish Rao that talked about brain fogginess. And I must admit, before I saw this, when a patient always told me they had brain fogginess. I always was wondering if they had celiac sprue disease, like Dr. DiMarino was talking about. But this, in this study, they come up with a kind of a syndrome, brain fogginess, gas, and bloating. And they found that this group, if they have a lot of gas, bloating, brain fogginess, they did have bacterial overgrowth, and they were often using a lot of probiotics. And the either the probiotics or the bacterial overgrowth led to what's called D-lactic acidosis, and that was thought to be the link to brain fogginess. So I'm kind of reluctant now to put patients on long-term probiotic. I thought I was changing the microbiome and doing that right now. I must admit, if I'm treating them for bacterial overgrowth, I put them on the antibiotics I want to treat, and that depends whether it's hydrogen or methane predominant. And then I followed up with about a month of probiotics to try to change the microbiome to what I might consider, quote, the good microbiome. And then I stop it and see how the patient does. Recently, our American College of Gastroenterology came up with, went over the, and came up with guidelines for irritable bowel syndrome. And there are a lot of them, and I tried to organize them a little bit. Again, they recommend this positive diagnosis category. Listen to the patient, listen to their symptoms, and come up with a diagnosis early on instead of trying to make it by exclusion, by ordering a lot of tests and things like that, and exclude it. Now, they suggest an IBS diarrhea, check for celiac disease. For IBS diarrhea, check maybe a CRP or a stool study to see if they could have biomarkers for inflammatory bowel disease. If they have significant constipation and they're not responding, you might want to consider an anorectal manometry to see if they have dysenergic defecation. And then we talked about these things for treatment. In this review, they suggested, again, avoid probiotics. They didn't recommend the bile acid sequestrants like cholestyramine that I talked about earlier. They recommended the PEG products like Miralax. They recommended against the fecal transplantation to treat IBS symptoms. That's more experimental. Actually, the most recent study implied that the success of the fecal transplant depended on what the donor's microbiome was. Now, we see a lot of these patients, they come back and they're not, some of them discuss about their persistent symptoms. So what can we do in follow-up, okay? Maybe take a look at the patient. You know, these patients have chronic symptoms. What does an improvement mean to them? What's acceptable? It might not be that we're going to get them totally back to normal, but what's the key? I like in my practice to delve on the what's their most bothersome symptom. Here are some strategies to optimize treatment. Encourage them to report any side effects. Be able to be contactable by phone or email. Luckily, in my practice, I have a barrier of a nurse that helps answer the phone calls, so I don't get overwhelmed that some of these patients can do. Try to keep the patients on the minimum dose. And sometimes we have to try combination therapies. And sometimes I'm using a symptom modulator with one of these other agents to help with either their diarrhea and constipation. And then if the patient isn't responding well and you're still concerned about it, then maybe try further investigations if you think that might be appropriate. So some of the key points in irritable bowel syndrome, I'm going to talk a bit about chronic constipation after this. I didn't want to confuse you that this is my last slide. It's a common disorder. It appears to be an alteration between the gut and the nervous system, where there's an interplay between the GI dysfunction and hypersensitivity. We discussed some of the recent guidelines, and then there's a number of options that seem to exist. And one of the key things we try, especially if IBS diarrhea, is the low FODMAP diet, There's pharmacologic. I didn't go over, but there are cognitive brain treatment therapies, things where they come in and talk with psychologists and psychiatrists. Now this is available as on the internet, and actually it's available so you actually don't have to see a psychiatrist on the internet. So it might be something to look into. I wanted to talk about it. Some of our patients have severe intestinal dysmotility. This paper that looks at intestinal dysmotility, it's very long, but the key thing this says is address the patient's primary symptoms and treat the malnutrition. If they have severe intestinal dysmotility, I personally am wondering if they have a lot of bacterial overgrowth. And often I'm testing for that to see if their symptoms might be related to this. But again, what's the patient's primary symptom in some of these severe cases, and try to make sure they stay, they avoid malnutrition, which in the severe cases can be kind of hard because unfortunately, sometimes feeding tubes don't work, and you might, in my practice, we might need to go to TPN. Chronic constipation is very prevalent. This is without abdominal pain, 15%. The symptoms can vary, whether we kind of talk about frequency. The patients often don't worry about frequency. They're worried about how much straining they're doing and how much bloating they have. And so they're often concerned about what I call the associated symptoms. But in the definition of chronic constipation, you don't actually need a decreased frequency to come into that. You can come in with straining and things like that to make the diagnosis. Again, just like IBS constipation begins with diarrhea, fiber supplementation, stimulants, or osmotic laxatives, and generally, most of the agents that are approved for irritable bowel syndrome constipation often get to be approved for chronic constipation. This slide shows the interplay. Some of the patients have slow colonic transit, and that's something you can detect with the SITS marker, radiopaque marker study. We do it with scintigraphy. Some patients can have a defecation disorder, dysenergic defecation. The problem is that they're not relaxing the puborectalis muscle, and some patients can have normal transit, but there can be overlap between the two. So sometimes patients have both slow transit and defecation disorder, so they might need a pro-motility agent as well as treatment with biofeedback. Here's a slide of how to evaluate chronic constipation. I always find this interesting because they start with chronic constipation, initial treatment, and then they go to anorectal manometry. Well, in the primary care center, this is not available. What you have available is colonic transit measurement. So usually in practice, the flow is you treat the patient's constipation. They don't improve. You might get a colonic transit test with radiopaque markers and see how slow that is. And then you refer them to GI for maybe anorectal manometry or further evaluation. So I always think that this is a little artificial because it's only something that actually academic centers can do. But it's a flow diagram that's actually interesting, gives interesting pathways. I mentioned before that a lot of the treatments for chronic idiopathic constipation are similar to irritable bowel syndrome constipation, with the secretagogues, the osmotic laxatives, as well as the 5-HT4 agonists. Here's a slide, data from several years ago looking at Prucalopride, which is Motility. This came out about, for us, about, I think, 4 years ago. It was in Europe for about 10 years ago, showing that Motility increased the number of responses compared to placebo, and both for women mostly as well as men. And the side effects are actually not not that common, but nausea, diarrhea, diarrhea usually for anything that treats constipation, abdominal pain, and headache. Interesting, in this 5-HT4 agonist compound, it did not have any EKG changes. So I've been using this if the patients don't respond to the secretagogues like Linzess or Amitiza. Now, a couple of years ago, actually, at our DDW meeting, the AGA and the FDA got together and they talked about some of how things got approved. And one of the things they talked about was Prucalopride, and how it got approved in the United States was mostly they used the European data to supplement the application. They mentioned again, no signal was seen in cardiovascular. And actually, this was new to me, was that they were concerned about suicidal ideation. And there were one or two patients. So actually, I tell the patients about depression and things like that. And I've had a couple patients where I've had to stop the medicine because of that. So it's now this idea of causing depression, causing other things is come up, like the tricyclic antidepressants in young patients. That's of concern. Prucalopride was of concern to the FDA in getting it approved. And at the same symposium, they also mentioned, talked about Tegeserod, because remember, Tegeserod was approved, and then all of a sudden on a Friday afternoon, it got taken off the market, and we were left they were calling on the weekend. And it got withdrawn for increased cardiovascular effects, and this line here. And then it was refiled because people looked at this and they said, yeah, they were there, but it was similar to placebo. There wasn't much change. And for Tegeserod, there's just a warning for this depression, suicide indication, very low, 0.08%. So that's 8 in 10,000 patients. It's only slightly higher than placebo number-wise. They suggested that if you try Tegeserod 6 milligrams BID, that actually it's approved for IBS constipation in women with few cardiovascular risks. You can only have one of the cardiovascular risk factors, and that you see them patient back about 4 weeks later. If there's no response, you stop the medicine. I've been using this agent, magnesium oxide, for constipation. I've been doing this for about 5 years. How did I start using it? I sent a patient to Mayo Clinic that I couldn't solve, and the patient came back on magnesium oxide and was doing well. And actually, I was interested at DDW. There's this poster, magnesium oxide, 500 milligrams TID, that it increased the spontaneous bowel movement from 2 to 8 per week. So this is 2 per week, or less than 1 every other day, to 8 per week to 8 per day. And so it seemed to help. I give magnesium oxide, I don't know, when I order on the computer, it comes out 400 milligrams twice a day, and the patients seem to do well. That's what I use a lot of that. I want to bring up opioid-induced constipation because there are agents that are approved. There's one other one that got approved also, but Amitiza is approved for that. And then Movantik is an oral agent that you can give. I sometimes go to Relistor. Relistor is available as an oral as well as a subcutaneous injection. I usually use Relistor if the patient has, in something I see, opioid-induced gastroparesis, because I'm afraid that the oral agent might not affect. So I often give those patients Relistor subcutaneously. I start out at every other day subcutaneous, then go to every other day. If it's the oral capsule, it's 3 of the 150 milligrams tablet each day. Now, we always thought that opiates delayed colonic transit, which they do, but there's also some literature that suggests they can get abnormal dyssynergic defecation. They can get dyssynergic defecation, and that can be the cause of their constipation also. But if the patients have constipation and then opiates, we usually go to one of these agents and monitor, because these agents here, Movantik and Relistor, are peripherally acting mu receptor antagonist. So I tell the patient it blocks the effects of the opiates on the GI tract, but it doesn't block the effect of the opiates on the central nervous system, and usually does not interfere with your pain control. So Dr. Lefton, in my talk, we talked about small intestinal and chronic motility disorders and IBS. I chose those because they're very common disorders that we all see. I tried to cover new approaches and agents to treat these disorders, especially IBS, and mentioned about some different ways to evaluate patients, like with the breath test, anorectal manometry, and transit tests for those not responding to treatment. Thank you for asking me to give this talk.
Thank you. You've once again proved why you are the master of motility, and we thank you for your input. There is a question about how someone in practice can get a breath test, where they should send the patient, or do they have to send them to a gastroenterologist?
Okay, thanks for that question. Actually, so we do the breath test at Temple, and the patient comes in and they stay for 3 hours and we do it, okay? There's actually commercial places that you can get the same, that the patient can do it at home. They can get the test tubes and the ingredients, and they can all do that at home. And actually, that's something that we were about to go to during the pandemic, because we shut down our lab for like 3 months. Now we're doing it with COVID testing protocol. So we do it at Temple, and actually a number of centers do them. You could refer them to us. And actually, you could refer the patient on your own to us if you send a prescription to that, or you can look up some of these companies by Googling home breath test for bacterial overgrowth.
A question came in about probiotics. When do you think they're appropriate?
I give them, if I'm treating for bacterial overgrowth, I give them either, if it's hydrogen predominant, I give them Xifaxan. If it's methane predominant, I give them Xifaxan and neomycin. I give them for 2 weeks, and then I give them a line afterwards. So that I give it to try to prevent them from recurring into bacterial overgrowth. I also give it if the patient has a lot of bloating, because the two agents I mentioned, I'm aware that there's data on them for Bifidobacter infantalis, which is the one, because it's generic, which is a line, but there's generic manufacturers of it also. And the other one it used to be called VSL number 3, it's now called Visbiome. There's evidence for each of those that seem to reduce bloating. So, and I see a number of patients that come in with bloating, and sometimes, I'm sure you have these patients, they bring out their cell phone and they show you their pictures of how bloated they are. And then sometimes I'm seeing these patients that are very distended. I don't know why they're distended even after CAT scans. I sometimes give probiotics. So to repeat, I give it after treatment of bacterial overgrowth, and I give it for patients with bloating.
30 years ago, there was a Dr. Alvarez who published an article in the paper, at least in Cleveland, where I'm from, daily. He would, for 30 years, he daily took a KUB to see if he could correlate how he felt with the gas in his stomach, and he couldn't. I don't think he died of radiation poisoning, but at least it was a study that he conducted and was able to not correlate how he felt with his X-ray. But as we say in gastroenterology, beware the man with a series of one. In gastroenterology, we also say the two most common problems are what you're eating and what's eating you. So certainly how you feel and what you're under can be a factor.